So, as you heard from the introduction, I am an oncology nurse. I do have a PhD in oncology nursing, so I'm the strangest of all. I'm a doctor nurse, so my mom thinks that's quite hilarious that I'm a doctor nurse. So I'm going to talk about person-centered, how we cultivate person-centered experiences, and I'm going to share with you what that looks like, and I'm going to talk about some particular things that we've done in our organization that are really making a difference to improve the patient experience. So it was interesting sitting at my table this morning and talking about the commonalities of the work that we all do in different countries. And I thought about this slide and I thought, well, that was a pretty good slide to start with, because I think that what we all struggle with doing is balancing the general and the unique. So every country, no matter where a person is diagnosed, every patient is going to need a good diagnosis, treatment options, and timely access to evidence-based care. And the evidence that informs the care that they get is international. But on the bottom, every person has unique elements about them and about where they're situated in the world that it's going to impact their ability to cope with what they are facing. So we're always in this situation of balancing those two. And some of those things that are really unique to the person facilitate their ability to cope really well. But some of the things that are unique to the person actually make it more challenging to cope with what's in front of them. And so if there are things in that person's experience that are unmanaged or unsupported, those things we often can refer to as distressing. They distress us. They make our experience more difficult to cope with because they exist. And so when we think about distressing elements, things that make us feel really anxious about what we have to deal with, we know that how a person experiences distress changes across time. It's not one thing. A patient doesn't have the same experience across their whole journey. What causes them to feel anxious or challenged is different depending on where on the disease trajectory they are having their experience. So whether someone is at the diagnosis phase and they're distressed because they don't know enough about their disease, they don't know enough about what's going to come at them, what treatments do I need, or they're moving into survivorship and they're like, okay, I'm through the treatment now, but what's the next chapter of my journey going to look like? What kind of supports can I do? What do I need to do to help myself be as well as possible? So that definitely is a very important element of this conversation today, because in order to support patients to be as well as possible, we actually have to understand where are they on their journey and what's distressing them. And that is not something we do once. That has to be done repeatedly. It has to be part of the core of how we care for patients. So when we think about that trajectory that I was just showing you, and the thought that things change across that trajectory, I love this model. It comes from the National Health Service in the UK, but really talks about what would it look like to actually engage with a patient at different points across that journey and give them excellent care? What would the patient tell us? How would we know we've done a good job in the healthcare system? And so this is really a model that talks about what would that look like from a patient perspective. So number one, the patient would say, my care was tailored to who I am and what was important to me. So that's the first element. Who I am and what's important to me at the various time points. My care enabled me to manage when possible, while ensuring that I knew where to get help when I needed it. So that whole piece around patient empowerment, and I can do things to help myself, but sometimes there is an edge to what I can't do for myself and I need help. Also, I was always treated with dignity, respect, and compassion. So that fundamental approach to how care is organized and how patients are treated when they're in our care. And the bottom petal on this flower says, my care was coordinated across time and it met my changing needs. So that idea that We have to actually touch base with patients along the way to say, how are you doing now? Is there anything else that you need from us? And then we have to help their care be coordinated across those multiple times. But in the middle of all of this is the core element, which we often refer to as the medical model or the biomedical world, around receiving timely access to excellent treatment and diagnosis. So every patient needs that from us. The pieces around the outside are really around how do we tailor that to the individual patient. So when you start to look about person-centered or patient-centered care, there was a great article or booklet that was published in 2007 around person-centered conversations, communication. How do we actually shift to build a system that looks like this, so that every one of our patients is saying that I have all of these things happening in my care all the time? And so this document, I'd highly recommend anybody who wants. It's very readable. It has some great resources in it. But basically, at the top, it says in order to have a person-centered care experience, we need three things. First, we need informed, activated, participatory patients and families. So we need to empower our patients and their families to be partners in their care, and they need to have the right information and knowledge on how to do that. Number two, we need our care clinicians, our physicians, our nurses, our social workers, our psychosocial oncology supports to have good communication skills that focus on how we engage with patients. So there's a whole bunch of skill development around that. And then the third element in this model talks about well-organized, accessible, and responsive healthcare systems. Am I talking too fast? Okay. I will try. So these three interrelated things help us to produce patient-centered care experiences. And so it's not all on the patient and the family, it's not all on the care provider, and it is not all independent of the system they work in. They all have to actually come together. And if those things happen, we have improved communication between patients and providers and families, and we have improved health outcomes because people understand what their illness is, they understand what can help me live the best life I can right now, and the output is that they have better experiences and health outcomes. So when we think about that, we're going to talk a little bit more around person-centered communication. This is again from that same article from Epstein and Street in 2007. These are the 6 elements that actually need to be addressed through how we communicate with our patients and with our providers. So we need to be open to responding to emotions, engaging information delivery, helping people make decisions, fostering healthy relationships between the care team and the patient, enabling patient self-management, and managing uncertainty. So these 6 items are all part of what we need, not only for our health team to think about, but our patients and families. So I like this slide because it really compares the responsibilities on both. So again, this is where at the beginning I talked about a mutual relationship, that this kind of care doesn't happen if you have a motivated patient and not a healthcare professional who's ready to engage on that same level. But this talks about the fact that it's both sides. So if we talk at the first one, clinician communication behaviors. Number 1, they have to be able to listen. They have to be able to listen to what is unique about this individual patient. And on the other side, the patient needs to have the ability to disclose their needs and their experience. What's distressing me? What do I need? Because the health system can't respond unless we can hear that from the patient. The next one, avoiding interruptions. So we have to be able to, as a healthcare professional, set time aside to be focused on what the patient needs from us. And on the patient side, the patient needs to be empowered to be able to share information about their symptoms and concerns. Organizing the visit obviously is a skill that the clinician needs. The patient needs to share information about their family, culture, and context. Soliciting patients' beliefs and preferences is the responsibility of the healthcare professional. The patient's responsibility is to discuss what they expect from us. So there's this mutuality between those two sides in this conversation. So what I'm going to talk about next is really one of the biggest areas of work that I've been working on is around patient-reported outcomes. So patient-reported outcomes are a tool that can help us have person-centered conversations. So what is a patient-reported outcome? Well, they're reported directly by the patient, so it's not the healthcare's perspective of how a patient is experiencing their symptoms or their concerns. It's coming from the patient in their own assessment of their experience. It complements but doesn't duplicate clinical outcome measures, so such as disease-free survival or other kinds of outcomes that are more commonly included in medical literature. And they measure things that affect the patient's quality of life. So this could be symptoms, it could be an actual quality of life measure, it could be experiences of getting the support that people need. And so why are using these kinds of measures or tools helpful to what we're trying to achieve, which is a person-centered experience? So number one, healthcare professionals need a window into the unique patient experience. So when a patient fills out a symptom report, it gives that healthcare provider a window into how are you doing today. And that window is actually a pretty quick view of some overarching areas where of common experiences that patients have. They can help us understand that unique patient's care needs and how they're changing. So this idea that repeated measures of having patients tell us about their symptoms, and if we're actually looking at them, they can help us understand on that care trajectory the ebbs and flows of where people's distress is coming from and how we might help that. So they can be used as a communication tool to really talk about what matters to the patient. They can drive efficiencies in the clinic by targeting attention to the most pressing concerns. So often our care interactions are very time sensitive. They're 15 minutes with the doctor, and you really need to be focused on what are the most pressing issues. And so having a tool that the patient can complete that highlights how their symptoms are being experienced is really helpful in terms of efficiencies. And it allows us to show that we're listening, that it is more than the physical experience of having the disease, that we are going to create capacity to actually talk about those elements of care that are beyond the patient's individual experience. So in Alberta, where I work, we've been introducing a common symptom screening tool, which we call Putting Patients First, into our clinical practice, and we've been doing that for about 6 years. But the most important thing is that having a form that a patient fills out that's about their symptoms does nothing to improve the patient experience unless the healthcare team looks at it and talks with the patient about it. So thus my beginning point around this is all about communication. So what we've learned and how we use it in our setting, the patient completes their symptom screening tool when they arrive at our clinical encounter. There is a conversation that occurs between the patient and the staff, and most often in our facility it's the nurse primarily that initiates this review conversation, but it could be the radiation therapist or it could be the oncologist. And we train our care providers to have a focusing conversation with the patient around what's most troubling to them, so what's most distressing at that point in time. We then move into shared decision-making between the healthcare provider and the patient around what might be most helpful. So what kind of supports or services or resources do we have in the system that might be most meaningful to meet what you need right now? And then after we come up with that solution, the patient agrees, yes, that would be helpful, then we activate it. So we take action. So we make a referral to the psychosocial team, or the patient takes the resources and reads about self-management and then comes back and talks about it at another visit. So depending on what that unique need is, that is really where the action is driven out of it. But the truth of it is that no matter how much knowledge we have as healthcare professionals about the disease and its treatment, there is always something that we need to understand from the patient. There is no removing the reality that the patient is the expert in their experience. And so this resource, this new practice of using a common symptom screening tool, allows that combination of what do I know about the disease, but now what do I know about the individual to really come together in meeting the very complex parts of how a patient's experience is impacted. So not only is the medical management of their disease important, but where am I going to stay when I'm in the city getting my treatment? What kind of knowledge do I need? Do I need to go to a class? Should I read a book? How am I going to pay for what I need to pay for because I can't work now? How is this going to impact my relationship in my family or my children? Can I get time off work? What are the forms I need to get filled out to actually take time to get the care I need? Well, all of these things play into what a patient needs from all of us. So I'm going to share an example from Alberta, and in Canada we've been very fortunate that we have a national organization called the Canadian Partnership Against Cancer. So the acronym is CPAC. This is a document that's free on the web called, it's an implementation guide for doing the work that we've done. So if anybody wants that resource, it's very easy to find on the website. But in that resource, they pulled together experts from across Canada, and they actually designed a symptom screening tool, which is on the screen, and I think I have copies of it somewhere here. You'll circulate them after. So basically on the top of the screen, the top of the form, there's 10 symptoms that the patient is asked to rank on a level of 0 being no symptom at all to 10 being the worst ever symptom. This part of the tool is a validated tool called the Edmonton Symptom Assessment Scale, used quite broadly in cancer patient assessments. The bottom of the tool we refer to as the Canadian Problem Checklist, and this really complements the elements that are outlined on the top of the screen to make it more whole person assessment. So this is where you include the patient can check off if they're having informational challenges, if they have work practical challenges around their family, emotional or spiritual. And so this gives us a really broad overview of all the elements that are pretty common to, regardless of what kind of cancer patients are challenged with, for us to respond to. And the second resource that I brought is a hand little tool, and this is what we actually train our teams on, our healthcare professionals. It's pocket guide. So this goes with the resource to say we actually have to have a conversation about what a patient reports on their tool. And it's a very simple conversation. It starts about, tell me what's most concerning to you today. How is that affecting your life, your day-to-day life? What about that troubles you the most? How are you handling that? What have you tried? What is working? And then just demonstrating some empathy around, I see that you have tried a lot of things, this must be difficult to cope with, so giving that normalization. And then the response around shared decision making. Oh, did you know we have a resource, or there's a support group, or there's an organization you can join, or depending on whatever the issue is, that's where the clinician being aware of organizations such as yours could be really helpful to that patient. And then at the end, after we've taken the action, we just make sure that the patient got what they needed out of the interaction. So anyways, it's for any of you who are interested, I brought some copies of that, but we have integrated that into our orientation with all of our staff. So what have we learned? So we've been doing this for 6 years. What we have learned about using this symptom screening tool is that it can improve clinical capacity to understand who's experiencing distressing symptoms, and it can be used to guide a person-centered conversation around how we can help patients get the support that they need. And it can be used to help triage patients who are really at high need of support. So those patients who are most struggling with high levels of symptoms. So if we only have a little bit of capacity, we really need to make sure that we're focusing in on those highest symptoms. What we've learned in Alberta, and we've just moved into kind of the ability to report these symptoms electronically, is that the paper resource that a patient is filling out, it can't help us know what the symptoms were on their last visit. So the ability to actually see what was that symptom on the last visit and where has it moved to now has been a real game changer in our organization. And I'm going to show you that in a second. It quickly, when we present it electronically, we can do some color coding. So we make high symptoms red. So the clinician can see, okay, this patient was in the green zone with low symptoms, but then they were in the moderate zone and now they're in the red zone. So this is a really significant issue that we need to draw attention to. It definitely helps flag the distressed patient quickly so that we can make sure we get the right resources and people involved in their care. And it really allows us to track how patients' symptoms change over time and making sure that if they're going to a different facility for care, that what they were struggling with at our facility is visible to the next facility when they're providing care. So now I'm going to just share how this all works in clinical practice. So this is actually my brother-in-law, Richard. Richard was diagnosed with lymphoma about 6 months ago. And so he definitely has struggled with high fatigue. He is, I think I used his example to really position us going forward about what he might need going forward. So he is a lawyer in Edmonton, which is a city in Alberta. He's 65. He had an irritating cough that wouldn't go away. So my sister said, you need to go get an x-ray. There's something wrong in your lungs. He went and had his chest x-ray, which showed a left mass in his left upper chest area. So initially they were thinking it was lung cancer, but on closer examination, they identified that it was actually a tumor on his rib, and with a biopsy confirmed lymphoma. And so with further workup, he was diagnosed with stage 4 diffuse large B-cell. So this is the screening tool, and this was from his first visit. So as you can see, it's completed by the patient, and you can see the second where the orange arrow is, he is already reporting 4 out of 10 in terms of his tiredness. So fatigue was a problem right from the beginning. Had very few other symptoms, physical symptoms. He had some anxiety, and his sense of well-being was maybe a little bit not as good as he was before he got a diagnosis. Then at the bottom, he also has checked off items around understanding my illness and or treatment, making treatment decisions, and knowing about available resources. So at a glance, you know where this patient's at. And so in the conversation, he actually said, when they asked him, as per that card, what's most troubling today, and he said, well, definitely knowing about my disease and the treatment options and making decisions. And so that was then a resource was given to him and my sister around the available lymphoma resources. And you can see, you can't see it here, but lymphoma, not the Lymphoma Coalition, but Lymphoma Canada is listed on as one of the resources for him to know about. So further on, now he's on RCHOP, getting his 4th cycle of treatment. And you can see from the symptom screen that now his fatigue is at 6 out of 10. So he's actually quite significantly challenged with fatigue. He's having some drowsiness, a little bit of lack of appetite, maybe a little bit of depression, anxiety, and then at the bottom, he's also checked off problems with sleeping. And so at this point, the conversation really is around his priority being fatigue management. He was really struggling. And in fact, my sister had called me and said, I don't know what to do. Like, this is unbelievable. He is so fatigued. We don't know how to manage it. And I was then able to refer her to the How to Manage Cancer-Related Fatigue resource, And we've created 6 videos that go along with the booklet that are actually available free on the internet, so anyone can access it. But they're short videos, maybe 4 minutes long, around self-management. What can you do to help yourself when you're dealing with fatigue? And so my sister and her husband were able to watch this together, and it helped her understand where he was coming from, but it also empowered them to know what they could do to help themselves. So this one, obviously he's not 1 year follow-up, but I hypothetically created a scenario of what it might look like when he's 1 year after his treatment. And so in this scenario, we know that fear of recurrence is quite a challenge after someone's done their treatment. So in this scenario, I have marked anxiety and depression on the higher end, as well as fears and worries and feeling alone. And this is an example of how when we have this conversation and using a common tool, we can actually target in that this person would be struggling with fear of recurrence. And so at that point, we can connect them to different resources around stress management or how to live with that. And so that's just at a very simple level how this kind of a tool used across different time points can help us tailor the care delivery to the individual patient. This is a screenshot of what our new dashboards look like, where we're showing the symptom changes over time. And so our clinicians are finding this, and our patients are finding this very helpful. When our patients check into our clinic, we have a print off of this that they get in their hand when they go into their clinical encounter. And so it's helping them have different conversations, again, thinking about how we empower patients to understand this is your symptom journey. This is what you've told us. How do you now use this to get the resources you need from your clinicians? So what we've learned in Alberta, over the last 6 months, we've been testing that, giving that to patients, reporting back to them around what their symptoms have changed over time. And so patients are over the moon at having this empowerment. They're telling us that it helps them understand how their symptoms have changed. It helps them understand where they may need more help. It's changing how they talk with their care team about where they're having difficulty. And it's allowing us to be innovative around how we support people, because not all symptoms need to be managed in the clinical encounter. We've been testing doing telephone follow-up after the fact if we don't have time in that clinic, and the patients have found that very, very helpful. And so I have, hopefully this is going to work now, it looks like it. I have a video that we've created in Alberta about this tool and how it's impacting patients. So this is Christy. Christy is one of our cancer patients. I believe she's a breast cancer patient. But it's just 2 or 3 minutes, so I'll play it. And she's talking about how she has found this useful in her experience. Oops. Yeah? Okay. Touch it. High tech.
It doesn't want to, but it should. Oh. Just give me 1 second.
We tested all of this before. It's like technology, hey? There. Perfect.
My name's Christy Sainchuk. I was diagnosed with stage 2/3 breast cancer at the age of 36. I think what happens when you're going through treatment is there's this sense of I just have to do whatever I have to do to get through the day. I did take note of how I was feeling during the 3 weeks between chemotherapies, but there's also like chemo brains. I would have a thought, oh, I should ask my doctor about this, and then all of a sudden it would be out of my head. Also, there's so much going on that I didn't really have a chance to like write it all down or really reflect on how I was feeling, but then I would fill out the distress form and it would jog my memory of like, oh yeah, I felt like this. I need to like ask the doctor about this, ask the nurses about this. I remember filling it out and going, this is helpful because it gave me like kind of like a guide. It also streamlined my thought process so that I wasn't going in with my head spinning. You hear about major things when you go through chemotherapy, like nausea, but it wasn't like the biggest symptom I had. My symptoms were more about like my mouth felt really awful all the time, my gums were really sore, my tongue felt awful, it was really painful, and that was one of the things on the form, and that took me to like the nurse, and the nurse would ask me about it, and then I got special mouthwash that helped me out and helped with some of the pain. Then when I was having a lot of pain, like obviously there's a scale on there that says how bad is your pain. And then when I was feeling sad and not feeling so great about life when I was going through my treatments, that also was brought up. And then I was kind of geared towards psychological services and the help that I needed there, which was has been very helpful for me. So there were days I felt better than others, and in weeks that I felt better than others. So I could actually kind of gauge my progress, like if I was feeling better or feeling worse. I felt like it kept everyone on the same page when I went in there. Like the nurse would leave with my sheet, and then the doctor would come in with the same sheet and go over what the nurse had talked to me about. I had 3 different oncologists because they were all going on mat leave, but I always felt like there was they were all on the same page and all asking me the right questions. Like I felt like I had really, really good care at the Cross.
So that was definitely one of our, we use this tool. Sorry, just make sure I can shut this off now. We use that video. It's not stopping. I'm just like trying to. Did I get it? Yeah, I think I got it now. Okay. So we use that resource when we're doing education with patients and families around why they need to fill out the form, because sometimes patients are like, this is a waste of my time. Why am I filling out this form? But it's all around connecting and empowering the patient to know that the clinician's going to look at it and do something with it. And so the digital report is really helping us get more buy-in from our physicians and our nurses, because it's really allowing them not only to see the symptoms a patient has today, but the symptoms they've had in the past. So using that ability to say, well, what's changed since the last time that people have been in? And the other thing that we've been able to do is it really helps see complexity. If you have a patient who's got really high symptoms and everything across the board, you need a different approach with this patient because they're really struggling. And so that has been really positive. And so I want to just show you this one, which is the flip side of Christie's story. This is now the oncology nurse or a radiation therapist and the radiation oncologist talking about how they use it to guide their care.
I'm Elisa Fairchild. I'm a radiation oncologist. I work at the Cross Cancer Institute.
My name is Bronwyn. I am a radiation therapist and I work in palliative radiation oncology.
I've been working in the palliative radiation oncology clinic since 2007.
Screening for distress is a tool that I use for every patient, regardless of the situation. If a patient is an outpatient that's being referred to us, then we have hyperlinked the screening for distress form into our referral form. So referring physicians can print it off, have the patient fill it out, and they can fax it in with their referral form, which is really nice. So it gives us a little bit of information about the patient before they show up.
If a patient needs palliative radiation, you can be sure that that's not all they need. And the screening for distress just provides a tool where patients can actually quantify what their needs are, which is different than looking at somebody from the outside and sort of deciding based on what they say or based on how they look. So it's a very important way for patients to tell us what they need.
The screening for distress is done at the time of consults. It comes with their information package when they check in. They fill it out, and then I use it to determine, what is important to them.
You never know what patients need or what struggles they're having or what burden they carry until you ask. And it may be that you're not the most appropriate or the best person to help address, but at least you can work with them to develop a plan.
It helps patients communicate with me what's important to them so that I'm not asking a bunch of questions that aren't relevant. It makes it I think, much quicker for me to hone in on the things that are really important and then allow the patient to elaborate in their own words.
The screening for distress has helped me learn that a lot of times I'm not the most important person to a patient's care plan at that particular moment. One example is a gentleman whom I saw recently with an anal canal cancer, and he had so much difficulty sitting that he really couldn't do it anymore. And it wasn't until he filled out the screening for distress and sort of specifically pointed out that that was impacting basically all parts of his daily life that it would have dawned on us to ensure that he was seen by an occupational therapist for a custom cutout cushion for sitting comfort. And he told me later that that was the best thing that anyone ever did for him, over and above the radiation or the analgesics that I provided.
Maybe there's something that's more important than the reason why we've brought them here today, and that's what we actually need to be dealing with. It did take me a while to get good with the form and just find out what works for me and what helps me to eliminate things for patients. That's where the art of having a conversation with somebody from a medical standpoint comes in, because you have to know how to cone it down a little and find what's important, but then also pick out the pieces of information that maybe you didn't think was relevant initially, but probably is in some way.
We've seen how powerful it is for patients to tell us their stories, and we are only able to help them if we know what the unmet needs are.
It moves away from the paradigm of the paternalistic healthcare provider telling you what the problem is and what we're going to do about it, and towards more of a patient-centered approach.
We've seen the impact that we can have if we work together as a team based on the results of the screening for distress.
You just have to find a way to make it work in your practice.
I work at the Cross Cancer.
My goodness. Okay, I think it's done. Let's see if we can get to the next slide now. Just click on the mate. There. And that was what I wanted to present to you today.